Welcome back to Diagnostic Imaging's Weekly Scan. I'm Senior Editor Whitney Palmer, and we're back again with you this week with the latest in radiology news and guidance. In the past week, news has emerged about the growing number of mammography practices that are opening up to provide needed screening services to patients. In fact, one analysis from breast imaging analytics company Volpara Solutions revealed that more than three-quarters of mammography practices are already operating within 10% of pre-COVID-19 levels. To help facilities that offer these breast imaging services, Diagnostic Imaging spoke with leaders from three facilities to identify some best practices that can help you most effectively, safely, and successfully reopen your practice. Leaders from Rome Memorial Hospital in New York, Oregon Imaging Center, and the University of British Columbia in Vancouver shared their personal experiences and outlined 9 best practices for bringing more patients into your office. Their guidance fell into several categories: patient contact and screening, personal protective equipment and safety measures that limit visitors and control patient belongings, changes to work hours and barrier installations that can limit patient contact, phased beginnings, and investments in new equipment. Although we know much more about this pandemic now than several months ago, questions are still swirling about how it will affect practices and workflow in the near to long-term future. To provide some clarity, or at least some direction for this mystery, experts from the American College of Radiology's Commission on General, Small, Emergency, and/or Rural Practices published insights in the Journal of the American College of Radiology about what practices might be able to expect in the coming months. Groups could find themselves faced with having to change recruitment efforts or pause employment offers. And the leaders also touched on strategies that could help practices triage imaging studies in an effort to grow volume levels. They warned against greater consolidation in the industry, and they highlighted some changes that could be permanent, such as more remote work options or more stringent cleaning and protection protocols. More information continues to surface about the neurological impacts of COVID-19. In research published in the journal Radiology, investigators from France identified 3 non-stroke neurological effects that appear to be the result of viral infection. They found signal abnormalities in the medial temporal lobe in 43% of patients with neurological complications, non-confluent multifocal white matter hyperintense lesions on flare and diffusion sequences with variable enhancement and hemorrhagic lesions in 30% of this group, and extensive and isolated white matter microhemorrhages in 24% of affected patients. The researchers urged for additional imaging and neurological follow-up. As most radiology practices and departments nationwide know firsthand, the COVID-19 pandemic has led to significant revenue drops. In many cases, the loss of revenue has topped 60%. As the healthcare system begins to pivot and more imaging facilities are opening their doors to an increasing number of patients, more attention is turning to efforts that can help groups recapture this money. Diagnostic Imaging spoke with Karen Holtzberger, Senior Vice President and General Manager of Diagnostics at Nuance Communications, to discuss the artificial intelligence and digital transformation tools that can help practices not only recapture lost revenue, but also assist in identifying patients who need services first during this crisis. She also shared the results of a case study from the University of Rochester. Here's what she had to say.
It's wonderful to be able to talk to you, Whitney. Thank you for having me.
Oh, it is my pleasure. Well, to jump right into the conversation, throughout the pandemic, the impact on clinical services has certainly been top of mind throughout the industry, but there's also been a significant financial impact as well. So from what you have seen throughout the industry and with your clients and with other colleagues, what is the financial impact that the outbreak has had on healthcare overall, kind of from a 50,000-foot perspective?
It's pretty incredible. As we all know, we read in the news, and I talk to many of our clients who are now thinking from this post-COVID, pandemic to now post-COVID recovery, bring patients back in. We know that the U.S. health system has lost up to $50 billion in revenue with the loss of elective procedures, patient visits, those types of elective, whether it's surgery or that hasn't happened in the past 13, 14 weeks when this all started and we really went into lockdown. And what's amazing that's happening now is a shift of, specifically in our industry that we serve through enterprise imaging or radiology, it was around how do we safely have the radiologists support the care teams and the COVID patients through decision support tools to help alert if somebody has something going on in the lungs that could be COVID related, getting those communications while keeping the radiologist safe, but that information through the report flowing to now bringing the radiologists back in, the navigators back in, and thinking about what am I going to do around revenue recovery because of the significant, costs that our health systems have seen with taking care of COVID patients, putting huge margin pressures on their operations. And again, the loss of up to $50 billion worth of revenue to the US health system alone, which has had significant impact on our GDP.
Absolutely. Well, within radiology specifically, have we seen specific numbers that we can point to, or even more specific impacts that you may have alluded to earlier?
Sure, absolutely. With 85% of the elective procedures canceled and not, having patients not come in, so the health systems could focus on, COVID patients and, turning different departments into COVID ICUs. Patients weren't coming in. We saw that downturn pretty immediately in just the number of radiology reports generated. Talking to many of our customers, they saw a downturn where they were seeing more COVID patients, but that only made up 15% of their monthly volume because most of their work is elective procedures or non-acute or non-urgent procedures. It's, I'm in for an ultrasound or I'm in for an x-ray or I'm in for a CT to, check out, for pre-op orthopedics, check why is my knee hurting me? Do I have arthritis there? Chest x-rays for lung cancer screening patients. All that came to a screeching halt at the end of March. We saw those volumes dip in our transactions through radiology reporting. We heard it from our customers. We saw it in our transcription business, very much what our customers were telling us too. I think what's positive though, and what is continuing to happen as the shift has happened of, keeping our doctors, our nurses, our nurse practitioners, the navigators, the radiologists safe and, taking care of the COVID patients to this shift of how do I now get the right patients back in for their follow-ups? And this idea about how do I start to recover from getting the patients the right treatments? How do I start doing this revenue recovery, through utilization of the imaging technologies that I have?
All right.
And that's a nice shift to the discussions that we've had about, I can't talk, I've got to go take care of my COVID population. It's incredible that the imaging departments are like silent to, okay, now it's about pulling patients back in.
Before we drill down into some of the things that can be done to help practices and departments on the road to recovery, without the proper intervention, what are the lasting impacts that these facilities and practices and departments might see if they don't kind of pivot and start to get the help that they need?
It's incredible. You just think about the patient outcome, and this goes back to what Dr. Wonkys talking about, 2 years, like independent of COVID and this pandemic that we're living through, is we all know incidental follow-ups, if not treated within as soon as possible or what the recommendation of the radiologist, and that patient falls through the cracks, the outcome of later treatment is really, really terrible. It's awful. I mean, it could be the patient outcome is that they died, And so let me give you an example of why really Dr. Wonkys did what he did 2.5 years ago about a backstop program. You have a workflow, and this is a typical workflow. When you think of, let me give you an industry statistic first. A radiologist on average every year sees, through patient imaging, between 10 and 20,000 exams, depending on their subspecialty. Out of those 10 to 20,000 patients that they're seeing through the diagnostic imaging, he or she's making recommendations for some kind of follow-up about 10% of the time. So if you do the math, they're reading 10,000 images. He or she's making 1,000 recommendations for some kind of follow-up imaging for that patient to go back for as simple as a pain management. You think about with breast imaging and breast screening, you move from a screening to diagnostic, come back for your mammogram or your breast ultrasound in 6 months. What happens is, in a lot of times in lung, is that they'll find an incidental finding that they think is suspicious for cancer. And we need a follow-up of the CT of the chest to make sure that this lesion hasn't progressed. Those recommendations, if they're not followed up on in that year and that patient comes back 2 years later, it could have progressed from early stage 1 cancer to potentially late stage 2 or late stage 3, which is more burdensome for the health system to take care of that patient. The outcomes are going to be much more negative than if they had treated sooner. So you think about the cost burden, the patient outcome burden, and then just really their own liability for that recommendation and didn't come in. Dr. Wonkys saw that in spades with recommendations in patients that were coming back 2-3 years later with late stage cancer, that if you go back to the trail of the report, that a follow-up recommendation had. And so in his mind, what can I do from a quality perspective just to make that patient outcome, much more positive? Listen, revenue came back in because that patient came back in sooner. Cost to treat that patient was much more, not as expansive as being late stage. And all these pieces about putting these quality and backstop programs together, it's really that quadruple aim, centered around the proper patient outcome. What's now so much more important, and we kind of put the COVID perspective on this with nobody coming in, patients being afraid, like if I go to the hospital with all these COVID patients, what do I do? That patients aren't going in for the treatments that they still need. Because this has happened, disease states haven't, stopped. Risk for stroke, risk for PE or AAA, those types of risks still have happened, but we've got to figure out how to take care of those patients. And so if they're getting the back in, what can you do back to the follow-up recommendations, again, going back to 1,000 recommendations, how can we use AI, natural language processing, that intelligence to help unlock those recommendations into the report and give tools to the navigators to say, look, this person is 120 days over their follow-up. How do I put a marketing plan in place? How do I get the right insights to bring that patient back in so he or she is treated earlier? This is this problem of recommendations being locked into the report, patients falling through the cracks. 60% of the times these recommendations are not followed up on. And it's now probably exacerbated because we've lost this time of no elective procedures, no appointments to these critical follow-ups. And so how can, we as Nuance, being a global leader in AI and AI technologies and the reporting pieces, help our clients, help the health systems, shine light, visibility, and tool sets to start bringing these patients back in. All with what started with Dr. Wonkys 2.5 years ago, that we're at this critical junction now because of the COVID pandemic.
Right. I want to circle back around in just a little bit about Dr. Wonkys and that particular case study. But dovetailing off of what you just said about the AI tools and the digital tools, they are certainly going to be a significant part of this recovery. So in what ways can we point to how they can transform support services and support practices for a greater, more maximized recovery?
Oh, absolutely. Because I think part of the problem that we've always had is that no one could easily get visibility to the data and insights of that data. If you think about, again, the radiologist makes the recommendation in the report, somebody needs to take note of that into the patient jacket and remember to go back. And so this is a heavy lift of clinical people supporting not just the radiologist, but supporting the primary caregiver, the ordering physician for that, to say, okay, 6 months, if the patient doesn't remember, I've got to remember on their behalf. All that manual work that nobody really has the time to do because of the patient populations that we're supporting. And so this is where technologies such as our AI tools of natural language processing can actually sift through and shine a light on where to start. You know, there's the American College of Radiology, we do about 450 million imaging procedures per year. And if you go back to, at the broader scale, as I talked about the example, 10% of the time of that 450 million of the patients that are imaged every year, 10% have some type of follow-up recommendation. How do you manage that? You know, and you can't manage it at scale without technologies like AI to be able to shine that light and put a concrete list of priorities together, you know, again, through AI, like, this is where I start, because it becomes almost overwhelming and why patients are falling through the cracks. This is, again, services, technology, intelligence at the right time, you know, for a navigator, the physicians to actually action and improve the patient outcome.
All right. So as far as specifics are concerned, when it comes to the resumption of continuity of care, are there certain nuts and bolts steps or things that these tools can provide that the radiology groups can grab onto and use?
Absolutely. And it's twofold. It's really about utilizing the technology, starting with the analytics of where to start, and understand what my population is or where I have to go. Is it in, you know, incidental findings coming from the ER for lung nodules in CT? Do I start with that patient population? How do I then put the right clinical users who understand that and the marketing programs together? Because you have to think about this, the health systems have to think about this holistically. And this goes back to what Dr. Wonkys has done, is that he utilized our natural language processing and some of our tools through Empower and Follow-Up Manager to put infrastructure in place on his radiology reports through PowerScribe, that data. But he knew data and getting the data organized and indexed properly wasn't enough. He had to put the right clinical leads in place to be able to do that. And then he put in 2 navigators to be able to manage that data, and not on a spreadsheet. That he needed other tools around work list optimization, task list, how do you close things out, those pieces. And then on top of that, he put in a communications platform of like, okay, this is how I'm going to, you know, do the follow up to the patient, work with the doctors who the patients are under, like primary care, and those ordering physicians. And so it's this comprehensive program of what I always call tech, but also the services to enable the tech through the health systems. Because your technology is only as good as the folks that are utilizing it and the programs, the continuous improvement programs you put in place around it. And this is where, you know, the work that Dr. Wonkys has done over the past 2.5 years continues to translate to reading practices, other health systems as they're expanding upon, you know, different, I'll say, disease state programs such as lung, for oncology, for pulmonary nodules, incidental findings, all those types of things. Because you've got to use tech with a great program that is supported by people.
Right. Well, in addition to being able to use AI to kind of pull information out of the report and kind of look at the hard numbers, what is the impact that the digital transformation tools can have on clinical safety and productivity, and even looking at the effects on providers, you know, when it comes to burnout and their own capabilities of keeping up with the workload?
It's all about where to start. You know, again, if you think about, I've got in my own population of 100 radiologists, they're each making 1,000 recommendations a year. That can be overwhelming about how to deal with the data. And productivity and efficiency is first things first. And how do I bring the most at-risk patients in that is going to improve the patient outcome, improve my financial outcome, you know, generate revenue, reduce liability, all those pieces. And that's, again, the marriage of, you know, technology and services and using AI tools, because it can be overwhelming. Like, okay, I've got all this data, it's now indexed to do something, but how do I do that so I'm not actually burdening the system or slowing the systems down to do that? And that's where AI can play the significant role with a clinical user to say, I'm going to go work on X first because Y is less risky. And then I've got this the ranked list of, where to start, how to kind of deal with these types of things and put these processes in place, because you have to parse through the data. You have to have an understanding of the data to drive that insight and to drive it into action. And that's where the technologies, really come into play.
All right. So wrapping all of that up and then thinking about the financial road to recovery, how does all of this come together to, I guess, make that most significant impact in helping practices start to recoup their revenue footing?
Sure. Well, if you think about it, there are two components to this revenue recovery of a patient coming back in. You got to get the right patients back in, and we need to get for the right reasons, the imaging modalities, CT, MR, back up and, full, have their schedules, maxed out. With that, and these two components is the technical component as well as the professional component that'll really help drive the road to recovery for not just the radiology department, because once the patients come back in to do their imaging, the doctors like the orthopedic surgeons or the general surgeons who need that imaging can then start scheduling surgeries and all those pieces. So imaging is going to always be the tip of the spear. The sooner we can get the patients back in for that critical imaging, the rest of, follow-up or that care pathway will also continue to happen. And I think that's why I'm so positive with the feedback that we've gotten, since here in the United States and really around the world too, as different states and countries are recovering and opening up through their phases, allowing elective surgery, bringing the patients back in for the needed imaging, which will then really drive the rest of the care pathways for that patient care, whether it's for surgery, whether it's for pain management, whether it's for just ongoing monitoring. So they got that, I hate to say it, full picture, through imaging for that patient so the care team can take care of the patient.
Right. So obviously these tools are beneficial to every practice and group, but are there differences between, I guess, size of group or type of environment, academic versus private practice versus hospital based? Is there, I guess, a difference in how they can best implement these tools and expect them to produce?
I think there are some, if you think about the academics, they just have, much more infrastructure and I think people to support quality-based programs. If you think about the pressures that the reading groups have, they've got very different needs. They're about efficiency, productivity, how do you recapture the patient to come back to that specific reading group? So I think it applies. I think the reading groups are going to, and we've seen this in some of our reading groups across the US who have adopted Follow-Up Manager, use it as productivity tools and efficiency tools for the front office to take on the burden of bringing the patient back in to recapture that revenue, that follow-up revenue from a technical and professional piece, especially if they have outpatient imaging centers with their reading practices. The academics are using this for quality-based programs, quality improvement programs, those types of things. So you see different needs, but implementation, but with different type of, I think, analytic and insight outcomes.
All right. Well, now you've referred to Dr. Wonky and his experience with these tools so far, and I'm hoping that you can provide a little bit of context on the goal of what he was doing, how it was designed, and kind of the impacts that particular experience has had and shown for the rest of the industry.
Sure. He came from this, he started as a quality and safety backstop program. He was identifying different examples where patients were coming back in who had clear recommendations for follow-up for incidental nodules, in the lung, so potential cancer, that were coming in much later than the follow-up was recommended, and these patients were going through the cracks. And so what he wanted to do was use analytics, NLP-based analytics, to identify those early at-risk patients to improve the quality and safety of the University of Rochester, that medical program. So it came from him that perspective of what can I do to dramatically improve patient outcomes. What happened as he's expanded this, he's improved communications with the referrers, he's improved communications with the patients, and he's also improved his own revenue recovery by bringing more than in the the first year of the program, 1,000 patients that weren't scheduled to come back in for their follow-up imaging, bringing them back into the system. So where he came from a quality and safety lens of improving patient outcomes, he also had the added benefit of bringing in what he calls revenue outcomes or financial outcome improvements too, by putting this program back together. And also really connecting an improved way with radiologists to the patient, or the radiology department to the patient, through the navigators that he's hired to work on the patient communication, the patient follow-up, to bring the patients back in, but also the communication to the referring physicians who maybe didn't also realize. So it's a funny gap. It's a bridge between who owns the follow-up. Is it the radiologist? Is it the ordering physician? And he really took it upon himself through a small grant from the ACR to actually start studying this and driving an improved patient outcome, which has turned into now an improved financial outcome, improved quality outcome, improved liability outcome, all the other things that came with it. But because he put it at the heart of patient improvement, how can I improve the outcome for the patient by bringing them back in sooner for these follow-up recommendations?
All right. Well, then how can we apply those findings to this particular environment with the pandemic and the need to bring patients back in, either those who have been lost to follow up for a variety of reasons, or those who have had their screenings or diagnostic tests postponed because of the outbreak?
Right. And this is, again, where the AI tools come into play. Let AI do the heavy lifting of the unstructured data to give insights to action for the nurse navigators. This can't be about, taking a piece of paper. I've got 150 reports. I've got to go through the recommendations, go figure out what patient this is, what's their contact information to go do that. Let AI take all this unstructured data that we have in our electronic systems, whether it's electronic health record, whether it's the PowerScribe report or any kind of radiology reporting. Let NLP, natural language processing, RAI tools, do that heavy lifting in conjunction with the tools that organize it, such saying, this is probably your first 20 priority. Go work that list and bring those patients back in with your IT tools around you for scheduling. What's the second list? And that's where the efficiency comes in. Insights of where to start, organized in a way that you can prioritize, and you've got confidence through the AI tools and the technologies that we have through follow-up tools, follow-up manager tools, to be able to action it quickly, effectively, and with confidence.
Wonderful. Well, I appreciate this. Is there anything else about these digital tools and the role that they play, particularly in this environment that we have right now, that you feel like is important to bring up and touch on and flesh out?
I do. I think, in just kind of to wrap this all together, it's about the partnership of, using AI and AI tools through natural language processing or other AI tools in conjunction with a strong program of clinical services. It's really we're at this crux, and I think COVID and this post-COVID recovery is really the accelerator to start using these tools now at scale, because you get back to this triple aim, or actually really quadruple aim, of improved patient outcome, improved revenue outcome, all at the benefit for the health system. And there's just this opportunity now, bringing the patients back in safely, to use AI tools such as our clinical language understanding and the technologies there to put these programs in place at scale. This is an opportunity I think, for all of us.
Absolutely. Well, Karen, I appreciate you taking the time today. Thank you so very much for joining us.
Of course. Thank you so much, Whitney. I really appreciate it.
Oh, my pleasure.